Thank you. All right, let's get this started. We're happy to have Dr. Kahn from Washington University, Dr. Timmerman's alma mater, right? And Dr. Kahn has taken a long route to getting to WashU, and he's went to the same med school as Dr. Adeel, and subsequently did his residency at Brown, and then went to WashU for his transplant fellowship, and thought maybe you should do another one, and went to Baylor for another year. And then we went into general surgery for, visa reasons probably, to Aurora Healthcare in Wisconsin. Then decided to go back to WashU, and also has done a robotic fellowship, HBP fellowship at Carolina. And then recently he was in South Korea learning living donor liver transplants, helping to start a living donor program at WashU. And as you can, he has published more than 20 publications in the world of transplant, and has contributed many chapters in lung garden as well as mastery of surgery by William John Dunnigan and Keith Lallamo's textbook on liver section. So we are very happy to have Dr. And he's kind enough to cover me while I was out of town for a week. Thanks for joining us.
I've been here for a week, and it's been, I gotta say, it's been great being here. Everybody I've interacted with in the hospital. When I was at the hospital, I can't believe how nice people are here. So it's been great. And I read somewhere a few years ago that South Dakota, that Sioux Falls was one of the most rapidly developing cities in the country. And after coming here, looking at the amount of construction that's been going on, especially in this cold weather, it's amazing. I've also been eating a lot. I've discovered some really nice eating places here. This bakery that I went to, patisserie. I've been going there every single day. It's mind-boggling how good that is. I don't think I've ever had desserts that good ever. So it's been great being here, and thank you to all of you. So today what we thought we'd do was talk a little bit about the current status of liver transplantation, just sort of a brief overview. So we'll talk a little bit about the history of transplantation in general, indications for liver transplantation, the current organ allocation guidelines in the U.S., a few words about the donor and the recipient operations, briefly the post-operative course of complications, and then if you have time, we can go over the indications and the treatment for hepatocellular carcinoma, especially from a transplant perspective, and then lastly a few words about the future of liver transplantation. So, the first real idea about solid organ transplantation came from Chicago, and Simon Flexner, in his works, mentioned that it would be possible in the future for diseased human organs to be substituted for healthy ones, including arteries, stomach, kidneys, and heart. He doesn't make any mention of the liver there, but it was interesting that about 50 years later, very short distance from there in Evergreen Park, Illinois, the first successful kidney transplant was done. And that was done in a patient with polycystic kidney disease who had a liver. At that time, they didn't really have any immune suppression, so the organ only lasted 10 months, but that was enough for the patient to overcome the acute phase of her injury and to continue to live on 5 more years. The first rail, though, one of the famous for kidney transplantation was in 1954 when Dr. Murray's team did the first successful living kidney transplant. Transplanted, so the two people in the picture down below on the right, they're twins. So he gave kidney from one twin to the other, and since they had identical genetic makeup, immune suppression was not an issue, and they didn't need anything. And he continued to live with a functioning graft for over 10 years, and because of that, he got the Nobel Prize for Dr. Murray and his team. But unfortunately, at around that time, they also thought about doing a liver transplant, but it remained experimental for the longest time. There were a lot of complexities that were added to this, mostly because of portal hypertension, liver disease, and just not having good tools at their disposal. So for about a decade, they just widely experimented on dogs and just tried to perfect the surgical technique for liver transplantation. Most of the work was spearheaded by Tom Starzl, who all of us know as the father of liver transplant. And it wasn't until 1963 when he did his first attempt at liver transplant on a human in a 3-year-old girl with biliary atresia. She was very sick and unfortunately died during the surgery, but that was the first foray into this previously unknown. They continued to work at it, and it wasn't until for about 5 years when they could do a liver transplant successfully on a human. And even then, it was a lot of controversy because most of the, liver transplantation was just sort of a Hail Mary pass, and most of the patients died. Like it was expected that they would die. So he received a lot of flack for that. But he persisted, and for the 70s, it was still considered an experimental treatment. And one of the main reasons why the patients didn't do well is if you could get it through surgery, there was really no immune suppression to prevent rejection, and then you would lose the graft, you would lose the patient. In the 1980s, they started to make some progress on that, and the outcomes after liver transplant started becoming better. And currently, it really is the standard of care for patients with end-stage liver disease and cirrhosis. So this is the data from the OPTN, which is the Organ Procurement and Transplant Network in the U.S. It looks at all the transplants done from 88 to 2017, and during that time there have been over 150,000 liver transplants done in the U.S., which comprises about 20% of them. And this data is just from last year. So last year we did 8,000 liver transplants in the country, which is the highest number of transplants done in the U.S. in a year. And it's still, even though it seems like a big number, but realistically, there are about twice as many people on the waiting list. It's not as bad as it is in kidney transplant, where there are 100,000 people on the list, but still there are a lot more people on the list who die on the list than who get transplanted. So this is, again, the data looks at the liver transplantation done in the U.S. from years. The blue line is the number of liver transplants over the past 20 years. So that line has slowly gone up. So there was a 10-year period from 2004 to 2014, or where the numbers were more or less the same and weren't really going up. The numbers have started to go up in the past 2 to 3 years, and that's purely because of the opioid epidemic. We are having a lot of more younger people dying of drug overdose, so we get more donors. The orange line is just the wait list addition. So it's not the wait list itself, it's just the number of people who are added to the list. And for every year, even if we do 8,000 liver transplants, there were 12,000 new people who were added to the list. And they keep on adding up to the people who are already on the list. So the real slope for wait list is something like this, where it just keeps on going up. And though this is not this graph doesn't really show it, but if you put a line, which is the red line for the number of transplants that we do, even if that goes up, there is an ever-increasing discrepancy between organ need and the organs that we have, and that bridge just comes on binding. What's the solution? So this cartoon kind of talks about we can go 2 ways here: either a baboon's heart and a pig's liver, or a pig's heart and a baboon's liver. It's funny, but it's really not, because we really do have a big shortage of organs that we need to try to address. So what are the indications for liver transplantation? So in the US, Hep C remains the #1 reason for liver transplantation at 30%. Alcohol liver disease is the second at 18%. Idiopathic autoimmune liver disease 12%. PBC and PSC are that, and then acute liver failure, MB, and metabolic liver disease are pretty uncommon. There has been an increasing trend towards doing malignancies other than hepatocellular carcinoma, like hydrocholangiocarcinoma. There's some centers doing it for neuroendocrine tumors, and more recently people have been talking about doing it for metastatic colorectal cancer as well, in very select scenarios. But the bottom line is, so hepatocellular carcinoma is still seen in up to 49% of the patients who undergo transplantation. Even if the cirrhosis is not the cause, there is a good likelihood that underlying is hepatocellular carcinoma. With the new treatments at Hep C, people are getting more and more curative therapy, so the number of Hep C transplants is expected to decline, but at least in the US, NASH is on the rise due to our morbid obesity epidemic. So we expect that our indications, wait list additions, and transplants are going to be more or less unchanged. So next question, where do the livers come from, or who delivers the liver? So a little bit about donors. So there are 2 types of donors, as we know: living donor, deceased donors. In the U.S., most of the donors for livers are deceased donors. Again, there can be 2 types: brain dead donors, which is, let's say, somebody has had a catastrophic injury and there's no blood supply to the brain, so they're considered as brain dead. So even though they have a blood pressure and heart rate, for medical legal purposes, they're considered dead. So that's how we get most of the donors, and it allows us to time the organ so that we minimize the hemodynamic instability component of things till just before the organs come out. The other type of organ donation is DCD, or donors after cardiac death. What those are is, let's say if somebody's been in a car accident and this they've got terrible neurologic injury, and the chance of meaningful recovery is essentially zero. But they still do have flow to the brain, so they're not essentially brain dead donors, but there's no other option other than to withdraw here. So these patients get evaluated for DCT donation, and what happens is you terminally extubate them, and once they die, you take the organs. So there's a little bit of a downtime where they're dead, so there's always a risk of thrombosis, and the complications tend to be a little bit higher in both kidneys and livers, but again, if the donor is young and healthy, then they are a very good option. So in the US, about 7,000 organs per year come from these two sources, and then living donation is something that's a lot less common in the US. It's only about 300 liver transplants a year that are from living donation. A little bit about listing and organ allocation. So once a patient is evaluated for liver transplantation, they are evaluated by the transplant surgeon or transplant team. They are listed for liver transplantation. The position on the transplant list is dependent on the MELD score, and as we know, the MELD stands for marker for end-stage liver disease. It's a marker for severity of liver disease, and it's a reliable predictor of 3-month patient mortality. It's calculated using serum bilirubin, INR, creatinine, sodium, as well as whether they're on dialysis or not. And just to kind of put that in context, so the higher the MELD score, the higher the probability of dying within 3 months. So we're looking at this figure. If somebody's got a MELD between 30 and 39, they've got a 50% chance of not being alive after 3 months. And this goes up to 70%, and the MELD is over 40. So it just makes sense that higher the MELD, the more priority you get, because you really don't have much time. So the organ allocation and listing is maintained by UNOS, or the United Network for Organ Sharing. It's the same for kidney as well as for liver. So they coordinate organ transplants in the US. They maintain the National Organ Transplant Waitlist, also work to increase public awareness about organ donation, and collects data on donors, recipients, and transplant outcomes. The UNOS has assigned the US into 11 regions called organ procurement organizations. Each one of them is a separate independent entity and is responsible for recovering organ and keeping them viable. It also transplants organs to recipients. Missouri, where I'm from, is part of Region 8. South Dakota is part of Region 7, shares it with North Dakota, Minnesota, and parts of Wisconsin. So how does the organ matching process work? So, patients are on a wait list that we list from our center. Once a donor organ becomes available, they are sort of matched against each other, and a list is generated for comes up with the transplant. Offers are made out of different centers, and whoever's at the top of the list, if they agree, they call in the patient, and then that goes on to transplant. So very similar to the way it's done for kidneys and for other organs. A little bit about the donor operation. So essentially there are two kinds of donors that we talked about. You can use the whole liver, in which the whole liver is taken out and then transplanted. That's how the vast majority of the transplants are done in the US, over 90%. And the other is a partial liver transplant, or a split liver, in which part of the liver is taken and transplanted. From deceased donors, usually when we take the part of the liver, it's for a small baby or an infant who would not be able to fit a full liver. Now that split can be done two ways. Either it can be done in situ, where we do it inside the donor with the heart still beating. So essentially do a hepatectomy without taking the vessels, and then take the vessels at the last minute. And what that does is that it minimizes the cold ischemia time. The other is ex vivo, where you take the full liver out and then divide it on the back table cold. And it's a little easier to do because there's no bleeding, but you do add to the cold ischemia time. If you plan it right, if the donor is really good, we can use the left lateral for a baby, and then you can use the tricep for an adult. So that's a way to expand the organ as well. But again, it only forms a small fraction of what we do. The other way is living donation, where we take part of the liver from an adult. You can either take the right or the left liver, depending on the needs for the recipient, and then transplant them into the recipient. And these are a lot more common in the West, because in the East, because they don't really believe in donating organs after death, so they typically rely on more on living donation. There's definitely an increased risk, but it's the only procedure that I know of where you have a 200% potential mortality risk. For a living donor, essentially first you start off by splitting the liver in the plane that you wanted to without taking vascular inflow, and then as the last step the vessels are divided. So in this, a right graft is used, so you divide the right hepatic vein, which is what you use for implantation. Inflow, you have the right portal vein and the right hepatic artery, which are divided just at the origin. The main portal vein and the left are stay with the donor, with the right are used for anastomosis, and then you divide the bile. Typically, the reconstruction requires a wide hepatogenostomy for restoring the bile continuity. The middle hepatic vein is a little bit of a controversy. Some people include that with the donor, some people leave it with the recipient. There's no one exact way of doing it, but whichever way minimizes the risk to the donor is the way to go. The recipient operation, so most of the time it's done through a bilateral subcostal, Mercedes-Benz incision. First step is a transplant hepatectomy. Vascular inflow and outflow are controlled. Short hepatic veins are taken down, and the liver is explanted. This is just a typical cirrhotic liver. And then we replace the deceased liver with the transplanted liver. So again, there are two ways of doing it broadly. So one way, the older way, is the bicaval anastomosis, in which essentially you put the liver in along with the full caval. So you do two anastomoses, one superiorly, one inferiorly. Then there's a portal vein anastomosis. Usually that's an end-to-end anastomosis, just to kind of minimize tension or laxity. Third is hepatic artery anastomosis, and usually it's also an end-to-end. We sometimes use the splenic artery or the GDA to create sort of a patch so that it's more wider. But again, there's no one way of doing it. And then the last is the bile duct anastomosis. Most of the time, you can put the bile duct from the donor to the bile duct of the recipient in an end-to-end fashion. It's something that you can't really do in a non-transplant surgery just because it strictures down, but with immune suppression it stays open. But sometimes you have to do Roux-en-Y, and we'll talk a little bit more about that in a second. So the second type, which is a lot more popular, which is how we do it, is the piggyback technique. And what the piggyback technique entails is that instead of clamping the cava and dividing it, you just clamp across the hepatic veins of the donor. So you see the clamp on the confluence of the hepatic vein to the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Then you kind of open them up to create one common orifice, and then the liver gets sewed on, the suprahepatic vena cava on the donor gets sewed on to this common cup. And what this does is that it allows you to not clamp the cava, so the patients tolerate that a lot better. This is the slide you see at the end, that's what it looks like. So the suprahepatic cava is anastomosis to the confluence of the hepatic veins. The lower portion, right there. So this portion is just sewed shut or stapled shut. So essentially, this is the only egress. And it kind of, it looks like the liver is piggybacking on the vena cava. So that's why it's called a piggyback. So like we said, that most of the time we can do a duct-to-duct bile duct anastomosis, but sometimes a Roux-en-Y is needed. Typically, we indicate it for when there is a big recipient and donor duct mismatch. One is big, one is small, and you can't really put them together well end-to-end. If the ducts are really small, for patients with primary sclerosing cholangitis, then you need to excise the whole bile duct. Patients with hypercholangiocarcinoma, for the same reason, the bile duct quality is very poor, and if they've had a previous screw, then you can just use that. So post-operative care, so most patients go to ICU for 1 or 2 days, sometimes longer, depending on how sick they were coming in and how the case went. We follow the blood work pretty closely for the first 24 hours, CBC, just to make sure they're not bleeding. Liver function tests to make sure they follow the expected course, and the INR, which is a marker of the synthetic function of the liver, expected to go up and start coming down. So you'll see with exams like for any other surgery. We typically leave a couple of drains in, one on the right side adjacent to the bile duct, and the other one on the left side, which sits on top of the liver, close to the cava, and basically looking for any bile or any excessive blood. Then we start everybody on immune suppression, so pretty much all of them get steroids, which is a pretty common combination. We typically like to wean out the steroids in the first few months so that they won't get 2 inches after that, but again, that also varies depending on the underlying cause and each patient. So very briefly, a little bit about post-transplant issues and complications. So bleeding, obviously, like with any surgery we worry about, it can be anastomotic. There are 4 vascular connections that can potentially bleed. It can be just retroperitoneal raw area. Very rarely it can be from GI bleed, especially if you have to do a RU, because the staple lines can be inside the mouth. It's not too uncommon to return to the OR for a washout or just to kind of clean things out a little bit. There are different indications that different people use. So typically, if the patient has received more than 5 or 6 units in the first day or two after transplant, that's an indication just to go back and wash out. You usually don't find anything, like with most hematoma washouts, but just getting that clot out often stops the process where they're continuing to lose, and that I think speeds up the recovery overall. Obviously, hemodynamic instability is a no-brainer, and then if there's ongoing pressure requirement along with transfusion requirement, that also is another indication. Bile leaks are again something that we do see fairly commonly. Biliary complications on the whole can happen anywhere up to 20% to 30% of the time. Usually leaks are diagnosed if you notice a leak in the drain. It can be seen as a collection of imaging, or if the patient is septic and they have a fluid collection that you aspirate and it turns out to be bile. Most of the time it is anastomotic. It can be from the cystic duct stump, because you typically leave that behind, and sometimes if you get to oversow it or the parts fall off and it just starts leaking there. Or if you're doing a split, it can be from the cut surface of the liver. There are different ways of managing that. In our experience, if they have an early bile leak, typically for us, we just go back to the OR and revise it. There are some people who manage them exclusively through ERCP, if it's a duct or through PTC, if it's but I think nationally, most people would rather operate initially if there's a bile leak rather than do other things. Hepatic artery thrombosis is a sort of a catastrophic complication for liver transplants. It's thankfully very rare. It's frequently, if it happens, the liver's gone, so just a new liver. And the problem is not that the liver stops working, the liver still has flow through the portal vein, but the biliary system relies heavily on arterial flow. So if there's an arterial problem, the anastomosis will fall apart, or they'll develop strictures, and essentially they just keep on developing liver and episodes of college disease. So if we do notice this complication, we like to listen and transplant them sooner rather than later, but they're still in the window where we can priority. Thrombectomy and anticoagulation is generally ineffective, so pretty much the treatment for this complication is to get into liver. Acute rejection, so that's not too uncommon. In fact, it shouldn't really even be considered a complication. We see it more commonly in young patients, those with autoimmune disease who have a very robust immune system. It's generally T-cell mediated. It's pretty much usually diagnosed on workup of elevated liver enzymes, and liver biopsy is typically required for diagnosis. Treatments usually requires increasing dose of immune suppression. If somebody, especially younger people, when they're not too compliant with their medications and they keep on getting attacks of acute rejection, it can lead to chronic rejection, which can be a problem, because that often means you need a new organ at some point. And if there are issues with whether they are taking the medication, then it becomes a different sort of an issue as well. You should give them a second liver. So, elevated liver enzymes is something that we see after liver transplant, and we are always obsessed about non-stop, same as a creatinine after a transplanted kidney. If it's going up, it's going down. Normally, the LFTs peak in 12 to 24 hours, and then a downtrend. They can sometimes, so the causes can include reperfusion injury, which is typically the most common cause, right? So you have a liver that's cold, it's been sitting in ice, all of a sudden you give it blood, so it does the hepatocytes take a little bit of a hit, and that's why you see an initial spike because of the damage, and that usually comes down and it's better. There can be vascular issues, so we get a duplex just to make sure the hepatic artery and portal vein are okay. Those are pretty uncommon for them to be down, but again, we like to assume the worst and start off with that. You can have bile leaks or strictures, which are usually picked up later, and again, you can either fix them surgically, they can be diagnosed with bile in the drain, ERCP or PTC showing any suspicious findings, or an MRCP. Rejection, we talked about, diagnosis and biopsy treatment is usually pretty straightforward. And then in people with hepatitis C or autoimmune disease or PSC, you always have to worry about disease recurrence. Same as if it's a kidney transplant and somebody who's at FSGS, you always worry, could it be recurrent FSGS? And that's something that's usually picked up with biopsy. Non-function, where the liver doesn't function at all, is thankfully very rare, and it does require urgent retransplantation. So the long-term outcomes after liver transplant. So these days the outcomes are really good at high volume centers. So 1 year patient survival after liver transplant is 91%, and this is using the OPTN data for pretty much all the years in the past 20 years. 1 year graft survival is 89%, which is also pretty good. And after 5 years, over 70% of the patients with the grafts are still doing well. So all things considered, those are pretty good outcomes. Needless to say, constant surveillance is pretty important and it's essential. So since we do have time, I thought I'd talk a little bit about liver transplantation for hepatocellular carcinoma, because we do see a lot of that, and up to almost a half of the patients that we transplant have either hepatocellular carcinoma that was diagnosed that we knew about, or things that should come up on explant pathology. So it's important to know a little bit about it. So it is the most common primary hepatic malignancy. Up to 85% have underlying chronic liver disease and cirrhosis. It is the most common cause of death in cirrhotics, and it is the fastest growing cause of cancer mortality overall. In 2005, there were 2.8 out of 100,000, which has now increased to almost 5 of 100,000 in 2015. So the mortality from that is going up, and it's something that we expect to continue to increase. So historically, the treatment options have been pretty dismal. Median survival for somebody with HCC is about 3 to 6 months. Surgery, like most of the things cancer-related, offers the best chance of cure. And surgical management of HCC falls into 2 arms, either resection or transplantation. So resection has been the treatment of choice for patients with limited hepatocellular carcinoma and normal liver or early liver disease. In other words, early cirrhosis of child's age. The 5-year survival for patients who don't have underlying chronic liver disease and undergo a successful resection are as high as 50%, which are pretty good but not stellar. However, as we talked about, most of the patients with HCC have underlying cirrhosis, so surgical resection is frequently not possible. Often they present at an advanced stage where they have bifocal disease where you can't really do a resection, or there is cirrhosis where even a little bit of resection can cause them to go into liver failure. Hepatic recurrence occurs in up to 80% of the patients undergoing even a curative resection with negative margins. And there are 2 reasons for that. One is tumor disease, and 2, a resection does not really address the residual liver, which is still cirrhotic and still is at risk for developing HCC down the years. So this is just one of many studies looking at outcomes after resection. This is the Mount Sinai experience from New York. Looked at 200 patients who underwent a resection, and what this showed was that they had a 45% survival at 5 years, and the recurrence rate was 65% at 5 years. So really not the greatest outcomes for supposedly resectable margin negative resection disease. So that brings us to liver transplantation for HCC. So, if you think about it, if somebody's got cancer in the liver, it's a primary liver cancer. If you take it out, put them in your liver, they should do well, right? But the initial experience was not like that. So there was a lot of enthusiasm in the early days of liver transplant for transplanting for HCC. It was considered to be the ideal therapy for hepatic liver disease, as it allowed for removal of advanced tumors, as well as the potential sites of recurrence in the liver. So it's however, when they started doing that, they were looking all comers, so people with massive tumors, with lymph nodes that were involved. So you remove the liver, put them in new one, then you put on massive dose of immune suppression. That's a recipe for disaster. So all of them had recurrent disease almost immediately, and most of them died. So in fact, the Transplant Association met in the 70s and the 80s, and they sort of said, okay, we're not going to transplant for HCC, so they banned it. It wasn't until the 90s when one of the Italian surgery groups, spearheaded by Mazzafero, published their sort of a landmark trial where they showed their experience in liver transplant for patients with small or early stage HCC. They looked at 48 patients, followed them up for a median of 26 months. They have a very restricted inclusion criteria, what they call the Milan criteria. So they only transplanted those patients who had 1 tumor less than 5 centimeters or up to 3 tumors, each less than 3 centimeters. And this corresponds to the ALTS stage 2 disease. And what they showed was that their 4-year survival using this restrictive criteria was 76% at 4 years, which is really good. Previously, it was unheard of. The disease-free survival, more importantly, was 83% at 4 years. So most of the patients did not recur when they were using this criteria. So, everybody took note. People did replicate the studies. They had similar results. And UNOS currently approves liver transplant for patients who meet the Milan criteria. But that can be an issue because most patients who have HCC typically have low MELD scores. It's picked up on early surveillance. So, somebody's got HCC, their MELD score's 9. They get listed, they're not going to get transplanted forever. So you can't really wait on somebody with cancer for 2 or 3 years for their MELD to go up. So what we do now is we allow those patients to get listed with their original MELD, but after 6 months, they're allocated exception points. They're assigned a MELD of 28. And the reason they picked up 28 is that's the median MELD for transplant across the US. So if somebody has a MELD of 28, the likelihood of them getting transplanted within a few months is pretty good. And again, that varies depending on where you are. Like we do it within 6 months, but if you're in California, you typically have to wait a lot longer. So the reason that they decided that the Milan criteria, they were not going to allow anyone more than Milan criteria to get transplanted or to get exception points, is that on the initial Milan study, they were, they thought that everybody was within Milan when they transplanted them. But like happens when you look at the explant pathology, there were, I think, 13 patients who had advanced disease, so who were beyond Milan at that time. And when they looked at the survival for those, their survival was only 50% at 4 years. So that's why they decided that Milan's going to be the cutoff. And if you do want to transplant somebody beyond Milan, you can do it, you just don't get the exception points for it, at least in the US. Living organ donation does become an option in those scenarios, but you're not going to go that. So then the other thing is, okay, so you get listed with HCC, but you're not going to get your exception points for 6 months. Should we do something in those last 6 months? And that's where local regional treatment comes in. So currently used local regional treatment options for treating Hep C, treatment HCC or transarterial chemoembolization, which is probably the most common. Y90 radioembolization or TARE. Then some people do thermal ablation, microwave, radiofrequency. Every center's got their own preference, and then radioablation as well. So these treatments have a very well-established role as a bridge to liver transplant. Somebody's got a 3 centimeter HCC, they just got listed, you treat it, you reduce it to 1 centimeter, it buys you time to get to the 6 months where you can get the exception points. But the role for as a downstaging measure is a little bit more controversial. So what I mean by that is, let's say if somebody comes in, they got a 6 centimeter tumor, right? So right now they're beyond Milan, they're not going to get listed. So what are you going to do? So one of the things that people started doing was using TACE or ablation to treat the tumor, to get the viable tumor to less than 5 centimeters. And now you downsource them to Milan. So as you'd expect, that meant a lot of controversy. People say, you still have big tumors, you're cheating, you're just doing this to get them in Milan. So there were a lot of studies that were done for it. And this is one of our initial studies in 2008. So what we presented our data, and we looked at outcomes in patients who initially presented with stage 3 or 4, which was beyond Milan, and then they were successfully downstage. So we showed that in those patients, their survival was actually even better than those patients who had stage 2 disease, but who didn't receive any local regional treatment. And again, there are a number of different reasons for it. One, you're selecting this group of patients. You don't see the patients who had the disease, who didn't respond to treatment and went on. And also, there is some thought that the patients who successfully downstage have favorable tumor biology. So the patient's going to be doing good no matter what. So there's you got to take this kind of data with a grain of salt. But it did show that it was safe and it could be done. And this again is a few. But this also is again our data. Looked at 269 patients, and we compared the outcomes in those who were within Milan at presentation versus those who were downstage. So those who were and this slide looks at the recurrent HCC data. So what we showed was that those who were successfully downstage had a recurrence rate of 0, compared to 8% in patients who did not require any treatment. And again, it goes to the same. These patients have a favorable tumor biology. They're going to do well no matter what. And the fact that they respond to treatment with tumor shrinkage is super selective. This is again one of my partners who actually went to school with in Ireland. Showed this in 2012 that currently liver transplantation for HCC has outcomes that are just as good as patients who are transplanted for non-cancer indication. So the 1-year survival is 90%, which is the same as for people who are transplanted for other reasons, and 5-year survival is 75%, which again is just as good as anyone else. Because of all this, currently liver transplantation has become a standard of care for management of HCC, because that is so much better than resection. So for HCC, the summary, liver resection is treatment of choice in patients without cirrhosis or with very early cirrhosis with limited disease. Liver transplantation is the preferred treatment for patients with cirrhosis in HCC who meet Milan criteria. The risk of recurrence is less than 10% in all centers. Pre-transplant local regional treatment should be considered in all patients with hepatocellular carcinoma if possible. And if they are successfully downstage, they should be transplanted. So we thought we'd just wrap it up in a few slides talking about the future of liver transplantation. So obviously, the big limitation in any organ transplantation is the gap between the need for organs and the organs that we have available. So we need policies to address organ shortage. We need policies to improve living donation, because if you do that, that's sort of an extra few organs that you can transplant and increase the overall number of transplants. We need to increase donor awareness. We need to make sure that more people become signed up to be donors, and that's one thing that we've been working very actively, and we've seen some results. For about 10 years, from 2004 to 2015, the number of transplants that were done in the U.S. was pretty much the same, but the list was going up. In recent years, that number has come up for a number of transplants that we do, and that's mostly just because of more people dying from it. But some of it is also because there are more people signing up to the organ. So both of those have to go hand in hand. There's a lot of talk about strategies to optimize marginal grafts, so grafts that are less than ideal. Let's say they're from older donors or donors with a lot of medical problems. Somebody who's obese and is a fatty liver, either you can turn them down or you can put them in someone if you think that they're going to do well. So strategies that can improve or optimize marginal grafts or decrease cold ischemia, just minimize the time the organ spends outside the body. Better matching of donors to recipients. So if if you've got a marginal graft, instead of putting it in a sick patient, put it in somebody who's healthier, so that they can survive the stress a lot better and the graft can do better. And then there are more research strategies like normal thermic liver perfusion, and that's something that we're quite excited about. Actually, we're doing one of those today. So what that is part of the Organox trial. They implemented that in Europe, and now they're currently doing a trial in the US. So it's normal thermic liver perfusion in a transportation system. So essentially, it's like a pump for the liver. I'm sure most of you have seen the pump for the kidney. The difference between the pump for the kidney and the pump for this is that this is warm perfusion instead of cold perfusion, and two, instead of preservative, it uses blood. So basically, you take the liver out. As soon as it's out, you put it on a machine, which kind of looks like this. It's sort of a big, cumbersome machine, but you can transport the liver in it as well. So the liver gets connected, so you put the cannulas in the portal vein, the hepatic artery, and the hepatic veins, so that you can measure what comes out. And you flush the liver with blood, and this is just bagged blood. And they can check, they can administer glucose, they can check the pH, check how the liver is functioning. There's also a tube that collects the bile. So what this does is that it allows the liver to overcome the cold ischemic insult, so that the patient doesn't have to see it. And you continue it for as long as you need to, well, not more than 24 hours ideally. And then once the time comes to put it in the recipient, just unhook the liver, flush it, and then just put it right in. So that really minimizes the time. What we've seen is that really there's almost no reperfusion injury with this. There's no hemodynamic instability in the patient, so it moves afterwards, and the fatty livers do really, really well. The liver enzymes don't beat that much. So we're pretty excited about it. It's a little bit of a pain in the behind, because you have to get the organ out. You have to be there. You can't just send the resident to get it. So you have to be there. You have to put it on the machine, which takes time, and then you have to wait 4 hours at least before you can use it. So, but the outputs are promising. So I think it's going to definitely be seen more of it in the future. So in conclusion, liver transplantation is a standard of care for many patients with end-stage liver disease. We have excellent patient and graft survival in high volume centers. The most important limitation is a shortage of organ donors. And again, there's one take-home message is, your yourself as well as other loved ones and friends. Adapting to us. If you can save some of their lives, then you can't possibly. That's it.